So next speaker is the Professor Ari Aburahma. Again. Okay. The title is What is the optimal sequence for the intervention in patients with combined carotid and coronary diseases?
Again, there's nothing to disclose in regard to my next presentation. Multiple reports have documented markedly increased prevalence of occult carotid stenosis in patients with coronary artery disease, especially those undergoing CABG, as we discussed in the first presentations. And two direct comparative studies regarding screening for CABG using the actual outcome of stroke and death have been analyzed. And if you look to this illustration, there are only two which really you could call they were great or good quality studies. If you look to the outcome of death on the top one of them show absolutely favoring screening. The other one was favoring, but not as much. But you look into stroke, the bottom of the illustrations, same two studies, one of them clearly showed benefit of screening for prevention of stroke for people undergoing CABG. Other one was just somewhere in the middle. Therefore, you really cannot feel extremely strongly except perhaps by saying is favoring screening for people undergoing CABG. Carotid stenosis in coronary bypass patient has been noted to be risk factor for preoperative stroke. That's well-known fact. Approximately 5 to 15% of patients undergoing CABG have carotid stenosis, which is known to increase the risk of preoperative stroke. Among patients undergoing CABG, the presence of carotid bruit and diabetes mellitus, which many of them do, will increase that possibility. Considering the prevalence of occult carotid disease, carotid screening for patients undergoing CABG is believed to be appropriate or justified. The evidence in favor of screening for patients with documented just coronary artery disease who might not be going any intervention is very less known. And with that in mind, we came with another question from our document for the carotid guidelines published again over 2 years ago. Question number 5. Is the optimal sequence of intervention in patients with combined carotid and coronary disease based on PICO? Again, try to look to randomized trial or observational study in both symptomatic and asymptomatic patients. Where is the evidence and rationale? Stage or synchronous carotid intervention in patients with 50 to 99% with history of stroke or TI in 6 months, which means symptomatic carotid disease, is supported by reported literature. There is no question the people who have symptomatic disease, carotid-wise, that is being justified. The optimal timing of this intervention, however, is unclear. Patients with above 70% symptomatic disease, minimal studies have addressed the timing of the intervention. Analysis of multiple observational studies in patients undergoing combined CABG and CEA compared with CABG first had similar risk of death, stroke, and MI. Comparing CABG first versus CEA first, again, the data showed comparable result for death, stroke, or MI. If the CABG first group were compared with CEA first group, the risk of death, stroke, and MI were similar. A small trend was found towards greater risk of MI if you do carotid first, and a little greater chance of stroke if you do CABG first. Evidence and rationale in patients who required CABG, therefore, prophylactic CEA and or CAS in CABG patient with unilateral 70 to 99%. Remember now, we're dealing with asymptomatic patients who might have risk of no more than 2% is probably controversial and would not be justified, at least for now, for unilateral disease. 2 randomized trials and several observation studies looked into this, and believe it or not, both show totally opposite direction. The series by Weimer showed the contrary to the series by Feldman, which was just skipped on the past slide. However, both series were small sample size. Therefore, you really cannot make a conclusion, should I do anything for asymptomatic disease who required CABG? Therefore, one must assess larger series to obtain a meaningful interpretations. So, another evidence showed here at JVS 2021, patient undergoing CAS, carotid stenting, trend was found for decreased mortality with CAS first. However, the number of patient assists were also small. If the option of carotid intervention is considered as either CA or CAS, when comparing combined carotid intervention versus carotid carotid intervention first for asymptomatic patient, the endpoint of stroke and death are slightly favored in the carotid intervention group. These data are based primarily on observational study. Therefore, what was our recommendation based on all these controversials and, as I suggested, relatively small size samples? In patients with symptomatic carotid stenosis, they probably have more evidence or observational studies have both CA and CABG suggest CA before or concomitant with CABG to decrease the risk of stroke and death. Sequence of which one to do first depends on your institutions. For example, over 10, 15 years ago in my institutions, when they were used to combine by the cardiac surgeon, the risk of stroke and or death were doubled. However, that changed in our past 10 years where the more modern surgeons have a better data where combining them was reasonable. Therefore, we're telling the people to look to your institution, decide, we know both need to be done. Should be done CA first, that's for symptomatic, followed by CABG. Should be done concomitantly, depends on your institution experience. The grade 2 evidence is still somewhat weak, C. In patients with severe bilateral disease, not unilateral, bilateral. Bilateral defined as above 70 to 99%, or contralateral occlusion and severe on the other side, again, suggest CA before or concomitant with CABG, again, based on your institution experience. The grade is still 2, level of evidence is C. In patients requiring carotid intervention, stage or synchronous with coronary intervention, suggest decision between CA and CAS based on timing of the procedure, need of anticoagulation on antiplatelet, and patient anatomy and characteristic. Grade 2 and evidence is a B. How about utilization of coronary artery bypass grafting combined or stage? Is there any trend towards we see this more often or less often? If you listen to me, it's less often, but let's share the evidence in the next 2-3 slides. Since 1972, there's 2 studies have examined national trend in utilization of carotid revascularization in CABG. Timuran of Dallas looked over 3-year period and found 97% of patients undergoing carotid revascularization and CABG during the same hospitalization had CA and CABG, whereas only 3% had CAS stenting and CABG with no significant change in the proportion over the period. However, Fidman from 2004-2012 noted approximately 2/3 of patients underwent combined CA and CABG and 1/3 underwent CA and CABG, and only few percent underwent stage CAS and CABG. The rate of combined CA and CABG decreased over the study period, and the rate of stage CA and CABG increased, which means there become more tendency toward stage CA followed by CABG later on. Multivariable showed from the same study showed that concurrent volume decreased by 7% per year, both stage and combined. Concurrent procedure volume significantly increased in urban relative to rural hospital, which makes sense. The author concluded that recent 20-year period, utilization of concurrent CABG and CA and CABG and CAS operation decreased significantly independent of the timing strategy, whether stage or combined. Thank you very much again for listening.